Hello, this is Fernando Gomez Sancha, and today I'm presenting a case of a patient whose PSA was 60. He was carrying a catheter, and he was sent to me to treat his retention pending a treatment for his prostate cancer. He was a very old man. I think he was 85 years of age. And it's an interesting case. I have done a lot of these cases, and it's quite interesting that one tends to think that these patients, if you do a minimal deobstruction, they will do well. So often at the beginning, I would try to take out the middle lobe and things like this. Also, considering that sometimes prostate cancer can invade the sphincter, can affect sphincter function, and there is possibly a slightly higher risk of incontinence after an endoscopic procedure to deobstruct these patients. So, but it was very interesting that when we did that, we would see these patients coming back again with the catheter, and so I started to think that why not to do a proper enucleation in these patients, and to my liking, I think they do much better, and it is sometimes technically a little bit more difficult than the normal cases, because often we see areas of the prostate where the planes are obliterated by the tumoral tissue, by the cancer tissue, and it is a little bit difficult. You have to invent the plane a little bit. So it's again trying to do what you usually do with HoLEP, but in a difficult pace. One of the striking things that happens often, and in this case it was like that, it's the sensation that the cystoscope is totally fixed. You cannot move the scope from side to side. It's very inelastic. The prostate doesn't. It's very rigid. So you have to carefully try to advance and provide mobility to the adenoma by gaining little advantages, little improvements, and going from one side to the other to see where you can gain this mobility. You will see that in some areas the tissue looks very yellow, very strange, and in some other areas we would have the impression that we are finding a plane. To me, these are interesting cases. They make the operation a little bit more difficult and more challenging. So I wouldn't probably recommend for beginners to start with this kind of operation. But if you do HoLEP regularly, I think you will find that most often, I would say always, in my experience, you can find a plane. Maybe it's not the best plane in the world. Maybe it doesn't exist anymore, the plane. That's why you don't find it. But you can do a cavitative technique and applying the same steps that we usually apply for the early apical liberation and the sphincter mucosa protection. I haven't seen incontinent patients so far. So here you can see the dissection of the posterior plane. Also, I think there is another potential factor that is interesting to take into account, and if the tissue is very hard, sometimes it can be, very, very hard. Often the morcellator will not be able to chew it, they will not be able to chew it, and then if you release the adenoma completely, you will have a lot of trouble morcellating the adenoma, and then you will end up going in with a resectoscope, trying to cut a loose piece in the bladder, which is quite challenging and difficult and sometimes risky. So you have to judge the quality of the tissue, because if you try morcellation, you better be lucky, and often what I do is, if I feel that the tissue is very hard, I will enucleate the adenoma and block, but I will not cut the 6 o'clock attachment at the bladder neck. And then I will resect the tissue. But of course, having a pedicle that fixes it to the bladder neck makes things much easier. And so I think I have often regretted more to try Morsellation in cases like this, although in this case I think it was successful. So take it into account. If you see that the tissue is very, very hard, maybe it's better to do a resection Morsellation at the end. Of course, this tissue is totally devascularized and there will be no bleeding, so you can resect quite safely. Here you can see I'm applying the same steps I usually apply for early apical liberation, just progressing a little bit slowly and well, trying to achieve the same goals that we achieve in a BPH patient. So this is the connection of the ascending plane from the right side with the plane from the other side. So although it's a little bit scary at the beginning when you enter and you feel the rigidity in the urethra and you feel that it's difficult to move around, of course you have to try not to exert a lot of force, but gradually the prostate starts mobilizing and you can do your enucleation. If you find a good plane, then it's a happy moment. If you don't find it, then you have to define one. Really, what we are trying here is to achieve a little bit better cavitation than what we would get from a channel TURP. Also, once you get comfortable with the laser, it becomes your instrument, the instrument you use for endoscopy, and you feel comfortable doing bladder tumors, you feel comfortable doing enucleation of all sorts of prostates. So really, I haven't found a case where I couldn't do this and I had to just do a classical channel TURP. And I have to say that we see these cases in Bulgaria where probably the primary care healthcare system, is not very developed, and patients go to the doctor when they have no bad symptoms, retention, things like this. So we see sometimes very advanced cases with very high PSAs, and even sometimes in patients who do not have access to drugs for the hormonal treatment of prostate cancer, we can do a simultaneous endoscopic enucleation of the prostate and a surgical castration at the same time. So, which is an option for these patients in this setting. Here you can see that the plane is not clearly distinguished. Also, I have to say, when you do en bloc, you get better ability to predict how the anatomy of the prostate is going to look like. I don't know. When you do a lot of these cases, then more or less you know where things are, and I don't know how to say it. So you can intuitively find a plane which is probably not too far from the real plane, if there is any. That's the vertical fibers at 12 o'clock in the bladder neck, so I knew we could enter. You see, with this virtual basket fiber and pulse modulation, the hemostasis we are getting is fantastic, which is also nice because you can spend the time of the operation worrying about the dissection on the plane and not so much having to concentrate on keeping a good hemostasis. So there we are. This is below the prostate. now, and trying to progress slowly. You can see how rigid the tissue is, and it felt very rigid, but slowly, without doing a lot of force, we can progress. We can progress with our dissection. There you are. That is the beautiful effect of this virtual basket energy double pulse, double bubble, as they call it. It really has an enhanced cutting ability. So in cases like this, it could be a big advantage because it really disrupts the tissue and helps doing this dissection. I really like these complex, more complex cases because they are a challenge, and you shouldn't shy out of these challenges, because there is a big potential to help the patients if you dare to go in and try. I am surprised. I would say probably every month I do a case like this or two, and it's quite interesting how well these patients, of course, improve their situation by removing the catheter and returning to normal voiding. So sometimes it feels like cutting through a rock. And I felt adventurous that day, and I decided to try to morsellate. Also, probably because I thought the adenoma was not very large. Sometimes you have the full house, the large glands, the prostate cancer. You do a rectal examination, and you can feel the stony, hard prostate, which was the case in this man. He had a very, very rigid prostate on palpation, and but I thought maybe the adenoma is not such a large one, and if we had to resect, it would be reasonable. And I took the risk of morcellating because I thought maybe if I'm successful, then it will be very fast and very nice. There you are. So carefully, you can see now, if you see the videos in the channel, I think the Bloc enucleation technique is quite mature now. It's very well thought, very well meditated. Most there are many papers are out about surgical technique, and some of them are published when the group has a reasonable experience, but maybe not such a big experience. And let's say the new concepts in these new variations or different variations of similar technique are sometimes more, how would I put it? Let's publish our own technique, but I have to say this is a technique that has been largely meditated upon. I have devoted many years and thousands of cases, several thousands of cases, to polish the steps, and I think it's now quite mature and everything makes sense. You see here, tilting the adenoma in the bladder is not very difficult. And here, if you wanted to resect, you would stop here and then do the resection. Maybe, well, there's a little bit of... So you need to leave a pedicle, especially if you use monopolar current, because if you use monopolar, there must be a way for the current to exit, and it will only cut if you leave a pedicle or if the enoma is in contact with the tissue. So, but as I said, I felt a little bit adventurous, and I decided to try to morsellate this time. If you do the resection, you'll have to extract the chips, and it brings back some memories of the TURP era. I haven't done a TURP since, I think, 2003. So it's been almost 20 years now without doing a proper, TURP. But there I went, and that is the fossa. It looks very reasonable. You see, you might be leaving some tissue somewhere, and because the planes are not so good. Of course, we are doing a palliative surgery, and removing such a large amount of tissue. Patients should do well, but it's better also. There's a responsibility for us when we treat these patients to try to make sure that they don't need to return to the operating room in the future. Now, it's if the catheter is taken out and they have a cancer that is going to compromise their lives in the future, of course, you would like to alleviate the situation so that they don't have to return again. So that was the motivation to remove this little piece. You see, sometimes you don't find the good or the best plane, but of course we are doing a cavitative technique, and it'll be better than if we do just a channel. The quality of hemostasis is amazing, and this patient had the catheter removed the following day and went home without any trouble. And yeah, you can see the rigidity of the tissue even up there. How it doesn't look as elastic and as nice as the normal tissue. So you see, even after an extensive experience, this can happen, and especially in these cases where the plane is not so good. But of course, also in the normal cases, so the trimming phase at the end, the revision phase is necessary, and even in the very experienced hands, sometimes we miss the plane. But then, of course, we can correct. There's no bad feeling about it. If it happens to you, it is absolutely normal, and it happens in the best families. So that's it, almost the end of it. And we will move on to morsellation soon, I guess. There we are. That bladder neck looks wide open. That's the edema from the catheter. And I think we will do a fast change. It was a 19-minute enucleation for a small gland in a relatively difficult case. So you see how polished this en bloc technique is, and how fast, because you can work continuously with very little pausing time, and it allows you to do these miracles where the patient is very fast, free from his catheter, and happier after this. Of course, the tissue was sent for histology. I didn't see the report. I operated this patient participating in a waiting list reduction campaign where we did 21 cases, I think, in 2 days. And so I found that the patient liked that. I had no. The surgery was indicated by a colleague. But luckily, the morsellation was quite good, and the tissue was chewable by the morsellator, so it was a nice resolution. You know, typically the morsellator chews the soft parts first, and if there is a very, very hard nodule, it will leave it for the end. But I think in this case, it was all okay. If the morsellation is inefficient, you have to be careful because the bladder will collapse because you will be sucking too much water. So you need to pause a little bit, let the bladder feel again before continuing. But no, this morsellation was surprisingly good. I don't like very much when the tissue is so close to the camera that you don't have any perspective. You cannot see the little black triangles. But I was in a safe position, a little bit over the bladder neck and almost inside the fossa. So I kept the pedal down and trying to conclude. Also, I didn't see that. I could see the opening of the blade too much, and I trusted that the bladder would keep reasonably filled during the morsellation of these pieces. That's almost the end of morsellation. And we were lucky this time. As I said, if the tissue is very, very hard, often I just resect it at the end. But that's almost the conclusion. Sometimes the blades can get obstructed with the tissue, and I don't know if in this case it happened. You see there's no suction on the tip because there's some tissue blocking, so we had to review it, I think. And yeah, morsellation is like that. Sometimes it makes you stop, and sometimes you have to look for alternative plans. When the pieces are very small, you can... Here I was trying to suck it with the flow of the bladder emptying, but it didn't fit. So I was not lucky. So I think I waited for the morsellator and finish. You could also go in with a resectoscope and use the loop to extract the final pieces. Sometimes you can extract it through the external sheath, and sometimes you just grab the piece, take everything out, and then the piece comes out through the urethra. But you have to be careful not to try to take out a very large piece, because that could mean some trouble. That's the end. That's the end of the procedure. I hope you enjoyed the video. All the best. Take care.